Dr. Keith Stockerl-Goldstein. I'm a professor of medicine at Washington University in St. Louis, and I'd like to welcome you to this session, Year in Review, the Evolving Field of Cardio-Oncology. We have three great talks. I think they're very exciting. I'm going to hand this over. We're going to try and stay exactly on time to Giuseppe, who will introduce the session.
So my name is Giuseppe Curigliano. I am professor of medical oncology at the University of Milano. And it's really my pleasure to introduce the first speaker, Professor Javid Moslehi, Associate Professor of Medicine and Director of Cardio-Oncology program in Vanderbilt University. He will address the topic of basic science and translational studies in cardio-oncology.
Thank you very much, Giuseppe and Keith. Real pleasure to be there via Zoom, and great work on the part of the organizers, specifically Teresa, with respect to organizing this, and I appreciate to be there. My job is over the next 12 minutes to bring you some perspectives on basic science and translational studies in cardio-oncology. I'm going to highlight a couple of papers that were published over the past year, but I'm hoping to also give you an overview of some of the technology that exists now that can really help some of the clinicians and help us move the field forward. So the field of cardio-oncology has really blossomed due to novel therapies, many of them targeted, that have led to various complications. These include trastuzumab or anti-HER2 targeted therapies that everybody knows can lead to cardiomyopathy, and other drugs like VEGF inhibitors that can cause hypertension, heart failure, and thrombosis. And one of the major underpinnings of this field, and for us to really help our patients, is to understand why mechanistically we get these cardiovascular sequelae. It's really important because not all cardiomyopathies are the same. And if anything, we've learned that from the cardio-oncology field. And the effects of the different drugs also go beyond simple systolic LV dysfunction. So a number of technologies are now in place to better understand and model these toxicities. For example, work done by a number of colleagues, among them being Dr. Burridge at Northwestern, Joe Wu, and many, many other people, have laid the foundation of, for the first time, using human endothelial, human-induced pluripotent stem cells that in a dish get differentiated into cardiomyocytes. And you can actually see that here. You can have one heart itself beat in a dish, and you can have a couple of heart cells in a dish, and you can effectively mimic a beating heart. The reason this technology is important, as I'll show you in the next few slides, is for the first time we have human cardiomyocytes that where we can use to model different cardiotoxicities. And really, seminal work done by Paul Burridge and others has shown that this can be really a personalized approach to patients. For example, you can get blood from patients who do or do not have trastuzumab cardiomyopathy and see if there are inherent differences once you differentiate these cells into cardiomyocytes. I think it's also important to note this is not by any means the only mechanism or the means to model toxicities. Various groups, including most recently Arti Asnani at Beth Israel, is using zebrafish to test cardiotoxic models. And we others have used rodent models to better understand some of the cardiac toxicities that occurs with various therapies. And this is effectively a beating heart of a mouse. It's small. This is only a few millimeters. And as you can see, this mouse that's now treated with sunitinib, you can mimic cardiomyopathy. And these are echoes that we can do in mice. And this and other platforms can allow us to understand better some of the mechanisms of cardiotoxicities. So where can we go from this? And if I can go to the next slide now, let's see if this works. All right. So one of the seminal studies published this year by Dr. Joe Wu and colleagues, and a couple of young stars here. June Rhee is on this paper, I believe. She's a rising star in the field. Ron Witelis and Nazish Syed. For the first time, they were able to mimic cardiotoxicity with trastuzumab. And this is important because many people have tried treating mice with the antibody. I think there is a little background, sorry. And so this has never led to fruition, partly because the Herceptin doesn't recognize mouse HER2. So in this very seminal paper, they were able to use doxorubicin as a control and be able to test what effects trastuzumab has on human differentiated cardiomyocytes. And you can look at things like viability, which in this case is not really affected much by trastuzumab, but a number of other things, including calcium signaling, which is differentiated with the use of trastuzumab. That's the TRZ here, and at least mimic one form of cardiotoxicity that we see in our patients. I think one of the other advantages of using this system is now being able to look at genetics. What are the different genes that go up or down as a result of treatment? And one of the major findings of this paper was the observation that trastuzumab really affects metabolic pathways and mitochondrial dysfunction that's seen with after you treated the cardiomyocytes with trastuzumab. And you can mimic that here by a number of mitochondrial assays that measure energetics. And this, I think, is a very important paper because it offers at least an example of a system that we can use to better understand toxicities. And it's a kind of thing many of us clinicians can take in and try to test in patients. So I think iPS-derived cardiomyocytes will be a major way for us to understand cardiotoxicities moving forward. As I mentioned, it's also important to note that iPS-derived cardiomyocytes is not the only way to test toxicities. We are increasingly seeing toxicities that go beyond systolic LV dysfunction. For example, ibrutinib and other BTK inhibitors cause arrhythmias, and cancer immunotherapies, including immune checkpoint inhibitors, cause myocarditis. And so one of the goals of our lab is to understand this using mice. Again, I think the mice nicely complement what's happening in the iPS cell or the cell-based model. So for example, in this case, Matt Fleming, who's here in my lab, has been able to model for the first time BTK inhibitor toxicity and at least see differential effects that occur between different models. And Walter Myers and Ellis Scriver, who are right in the front here, have been for the first time used transgenic and pharmacological treated mice to mimic checkpoint inhibitor myocarditis. And you can almost immediately see potentials and at least testable hypotheses that we can take to our patients. I think one of the other things we have to be cognizant of is the growing explosion of cancer immunotherapies. This is Alan Beck, who's a rising star in the field, who's at UCSF, and this is a paper that he has coming out later this year, describing what these immunotherapies are, because beyond immune checkpoint inhibitors, we're increasingly seeing more complex cell-based immune therapies that may have various cardiovascular sequelae. And it's really important to also for us to adapt technologies that allow us to now for the first time interrogate why inflammatory heart disease occurs. Again, inflammatory heart disease is going to be very different than probably what we see with doxorubicin and or trastuzumab. And some of the technologies I think everybody should be aware of, one technology that's been around is the use of flow cytometry to better differentiate various cell types that go into the heart. In this case, we're talking about myocarditis. So now you can use this, and using some of the mouse models we have created, we can start thinking about what are the different cell types that go into either human tissue that we may get or mouse models that we may have. And I think the other important technology for people to be aware of is the use of single-cell RNA-seq, because when you look at the entire flow, you get the whole heart tissue. And what single-cell RNA-seq allows you to do is differentiate cells. You can kind of dispatch the heart and dispatch the cell using genetics to guide what cell type you have present. And now for the first time, you can do, for example, RNA-seq at a single cell level. And this can introduce a lot of new pathways and ones that we're interrogating with various immunotherapies. And last but not least are the growing appreciation that T cells mediate some of the toxicities. And you can use a number of other technologies as shown by this very talented MD PhD student in our group, and specifically my colleague Justin Balko's lab, where he's using TCR sequencing to really interrogate the type of T cells that are present in a myocarditis case. And using this and other technologies, we have been able to, for example, understand why abatacept, a CTLA-4 Ig, can be a treatment mechanism for myocarditis. The dogma, again, is that the drug uses bindings to CD80-86. By using single-cell RNA-seq, we've been able to distinguish and isolate CD80 positive T cells. And we think abatacept may have a mechanism in terms of targeting T cells directly, something that goes against what we normally accept abatacept to do. I think the other couple of very quick points I want to make is the growing appreciation that cardio-oncology goes beyond cardiotoxicity. And there have been some very nice work done on this. We know common risk factors predispose to cancer and heart disease, but we also are appreciating over a couple of seminal papers that came out over the last few years that heart disease itself can push cancer and can make cancer grow. This was first demonstrated in this nice paper by Walter Myers and Rudolf de Boer in Holland. And most recently, and I think one paper everybody should read, is this excellent work by Catherine Moore, where in this case, myocardial infarction in mice, and they have some nice human data to show this, potentiates breast cancer. Again, this is what we can refer to as reverse cardio-oncology. And so as a final slide, I think it's important to note that preclinical models are very important, and they can help us better understand mechanisms of cardiovascular toxicities from cancer therapies. They're especially useful in delineating mechanisms of targeted therapies. And I think they can provide us insights into human cardiovascular biology. I think it's important for us to especially use novel immunotherapy techniques and specifically technologies like single-cell RNA-seq as we now interrogate and encounter more complex cases that go beyond simple systolic LV dysfunction. And I think it's also important for us to think of our field as not just a toxicity field, but one that really looks at intersection between cancer and heart disease. We are starting a number of initiatives within the American Heart Association to better understand both the basics models, but hopefully kind of introduce some funding that can help the field forward. One paper I would think it's important for everybody to be looking out for over the next year is an AHA statement on the preclinical models in cardio-oncology. And this is chaired by Arti Asnani, who's at Beth Israel Hospital. And as a last segment, again, the AHA is we have a new group of very talented people that are hopefully we are hoping to help move the field forward. One of the goals that we have had within this AHA committee is to both bring in new talent, new young people, what we call fellows in training within the AHA to the group. And we've been able to recruit 4 young, talented fellows as part of this. And I think the big news for the coming year is, and I don't know if this is going to work, is the use as an SFRN that will be announced by the AHA. That will be $15 million dedicated to cardio-oncology research. The RFAs should be coming that over the next few months. Thank you, and I'll stop there.
All right, thank you very much, Javid. I'd now like to introduce our next speaker, Dr. Miguel Canales, who will be speaking about top clinical advances in hematology. Dr. Canales is the section chief of hematology, as well as the director of their hematopoietic cell transplant and cellular therapy program at La Paz University in Madrid. Dr. Canales.
Thank you very much for the kind invitation to participate in this virtual meeting. My topic today is top clinical advances in hematology. these are my disclosure. So over the last years, our understanding of the cancer biology has increased quickly, leading to new types of targeted therapies as well as immune and cellular therapies. The treatment of lymphoproliferative disorders is a clear example of the changing therapies in hematological malignancies, but also the treatment of myeloid disorders has also evolved. So currently, we are moving forward to chemo-free scenario in the treatment of hematological malignancies. The result of treatment changes seen across all hematological malignancies is that an increasing number of patients are living now with new and chronic toxic effects. So the field of cardiotoxicity is quickly expanding. Additionally, different agents differ in their cardiotoxicity potential even within the same class of drugs. Moreover, these toxicities are often unexpected and frequently are detected after approval. By last, the exact mechanism of these toxicities, the risk factor, the natural history of these complications remain poorly understood. So, in addition to heart failure, classically associated with conventional chemotherapy, side effects such as hypertension, vascular events, atrial fibrillation are common toxicity for targeted therapies. Moreover, on-target and off-target effects can cause cardiovascular toxicity. The most widely studied agent is ibrutinib. Ibrutinib is a BTK inhibitor approved for the treatment of different B-cell lymphoid malignancies, such as chronic lymphocytic leukemia or mantle cell lymphoma. As you can see, 15% of patients develop AF, but it's more common hypertension that has been described in up to 70% of patients with a longer duration of the treatment. Minor bleeding in the 45% of patients or mild thrombocytopenia are also frequent adverse events in patients treated with ibrutinib. Beyond ibrutinib, a second generation of BTK inhibitor is acalabrutinib. Acalabrutinib has been studied in previously treated patients with chronic lymphocytic leukemia. In this study, acalabrutinib is compared with idelalisib or immunochemotherapy, and as you can see, the use of acalabrutinib in this population of patients is associated with a longer progression-free survival, even in this population of patients. This population of patients are patients with TP53 mutation that represent a poor prognosis CLL group of patients. So it's a significant advance in the treatment of lymphoproliferative disorders. In the first line setting, in this randomized trial, acalabrutinib, either alone or in combination with a monoclonal antibody like obinutuzumab, is associated with a significant improvement in progression-free survival. We know that acalabrutinib is a highly selective BTK inhibitor in comparison with ibrutinib. So in addition to a high efficacy, we expect a minor complication with the use of acalabrutinib. And in this study presented in the last ASH committee, this meeting this year was also virtual, you can see that the long-term tolerability of acalabrutinib, the atrial fibrillation or major bleeding was severe in less than 5% of patients, and hypertension is described around 10% of patients. The other drug that is changing the natural history of CLL is venetoclax. Venetoclax is a BCL2 inhibitor that releases pro-apoptotic protein in order to initiate apoptosis. And this agent is approved not only in CLL, but also in older patients with newly diagnosed acute myeloid leukemia in combination with hypomethylating agents. Here you can see the result, the main result of the CLL14 trial in the first line setting of chronic lymphocytic leukemia, and the combination of venetoclax with obinutuzumab is associated with a longer progression-free survival in a patient older than 56 years. And regarding the acute myeloid leukemia, in base of the result of this study, venetoclax was approved for the treatment of older patients with AML. You can see the significant improvement in overall survival, and this study is the proof of concept that AML can be effectively treated with chemo-free strategies. It's a novel concept in the treatment of a very aggressive disease like AML. Additionally, the cardiovascular toxicity of venetoclax is minor. It's a well-tolerated drug with the AF is the severe EF is described less than 2% of patients, or for instance, hypertension is described in less than 7% of patients. But in acute myeloid leukemia, more interesting are the FLT3 mutations. These mutations, the internal tandem duplication mutation, are very important because a third of patients with cytogenetically normal acute myeloid leukemia have this mutation, and these mutations are associated with poor prognosis because of higher relapse rate. And here you can see the huge development of different agents to add about this mutation. You can see first generation of drugs, second generation, and here you can see a well-known agent associated with a relevant cardiovascular toxicity, such as sorafenib. Sorafenib induce hypertension in up to 42% of patients, in addition to acute coronary syndrome or QT prolongation. But fortunately, we had newcomer in the treatment of this disease, because the prognosis of a patient with AML with FLT3 mutation is very poor. So new agents are necessary to improve this result. So here you can see the result of this trial. It's a randomized trial with gilteritinib in comparison with conventional chemotherapy. And here you can see the significant improvement in overall survival. So this strategy is a very promising strategy in another poor prognosis hematological malignancy. Additionally, the cardiovascular toxicity of gilteritinib is minor. Hypertension or hypotension is described less than 10% of patients. So it's a well-tolerated drug from a cardiovascular point of view. And let me now move on to lymphoma, because the last year FDA approved the first combination without chemotherapy for the treatment of indolent lymphoma. The combination of lenalidomide plus rituximab has demonstrated in this randomized trial significant improvement in progression-free survival in the whole population of patients with relapsed follicular lymphoma. But it's important also that this population of patients who progress at the 2 years after diagnosis is a very poor prognosis population with lymphoma. So we need new agents for the treatment of this patient, and in this particular case, the combination of lenalidomide with rituximab improved the results in patients who progress early. The cardiovascular toxicity profile of lenalidomide is well known. Lenalidomide is binding to cerebrum protein, and his effect on Ikaros and Aiolos can be central in the development of these cardiovascular effects. So, in conclusion, targeted therapies are leading a swap in the management of hematological malignancies. So, accordingly, the field of cardiotoxicity induced by this agent is quickly expanding. As previously mentioned, these complications are often unexpected and frequently detected after approval, so we need a long-term follow-up of this patient to detect this complication. And so actually now in the personalized medicine era, cardio-oncology is more necessary than ever. So thank you very much for your attention, and this photo was taken in our last non-virtual meeting celebrated 1 year ago in our hospital, and I hope in the future we can meet again. So thank you very much for your attention.
Thank you very much, Dr. Canales, for this wonderful overview on hematological malignancies. It's my pleasure now to introduce Professor Christine Brezden-Masley, that is the chair of the Medical Oncology Department in Mount Sinai Hospital and the University of Toronto. And she will discuss about top clinical advances in oncology. Very challenging.
Thank you very much. Thank you for the lovely introduction and for allowing me to participate in today's Global Cardio-Oncology Symposium virtually. Hopefully next year, this will be in Toronto, Canada, where I'm currently residing today. So today I'm going to be talking about the top clinical advances in oncology. I'm just trying to get to there we go. These are my relevant disclosures. So if we look at oncology globally, as we know, this is certainly a global problem. It is the second leading cause of death worldwide. And when we take a look at the most common malignancies, which will be important in terms of how we actually treat these patients, we look at lung, breast cancer, prostate, colorectal cancer, and stomach cancer. In fact, globally, stomach cancer is the third leading cause of cancer deaths. And as you can see from the predicted global cancer cases, this will continue to rise. And when we look at Canadian statistics, cancer actually is the #1 cause of death in Canada, and 1 in 2 of us will develop a diagnosis of cancer in our lifetime. That doesn't mean that we're going to die of the disease. 25% of us, unfortunately, will succumb to cancer mortality, but a 5-year cancer survival is about 63%. So we think about it, 2/3 of our patients that we treat with cancer therapeutics will actually survive the disease. And so this is, of course, extremely important when we are looking at therapies that we give to patients in terms of long-term outcomes. I borrowed this slide from Javid, thank you. You've already seen it. And it's very important because we certainly know and have learned about the toxicities of our classic chemotherapy compounds, such as anthracyclines, HER2-targeted therapies, antimetabolites, that really have been shown to lead to really cardiac damage. And the way we've measured it is drops in ejection fraction. Of course, there's vascular injury with the VEGF inhibitors, but now we're actually looking at more selective targeted therapies, these tyrosine kinase inhibitors that Miguel just presented for hematology malignancies, and of course, cancer immunotherapies. So if we focus just on these 3 classes of tyrosine kinase inhibitors, now the new novel HER2 targeted therapies, these are antibody drug conjugates, and of course, immunotherapy, of which you'll hear more about later on in today's session. So if we look at these small molecule tyrosine kinase inhibitors, and I apologize, this is a great review article. This is what has recently been accepted at the FDA, so approved at the FDA. All of these IBs, which are these small tyrosine kinase inhibitors, look at different ATP binding domains intracellularly, which may share similar targets with leading to cardiotoxicity. And so here, when we take a look at the incidence of cardiotoxicity with these TKIs, there's 73% that have been reported. This is quite significant. The most common is QTc prolongation. There's, of course, vascular injury. There's injury to the myocardium, leading to left ventricular dysfunction, and, of course, with arrhythmias. So for us as oncologists, we are now becoming more attuned to actually doing routine ECG monitoring with any compounds that are leading to QTc prolongation. And if there's any evidence of leading to causes with changes in ejection fraction, we're looking at cardiac imaging. And most recently, we really moved to echo as opposed to MUGA scans. The question, of course, is, should all these patients starting these certain TKIs be reviewed by cardio-oncology prior to starting? This is now the importance of developing these cardio-oncology clinics, which you heard in the beginning of this morning's session. And some of these TKIs are now moving into the adjuvant setting. So many of us have been using these in the metastatic advanced setting. These are heavily pretreated cancer patients, typically, who have, of course, as you heard, reverse cardio-oncology, similar clinical attributes or similar causes or comorbidities that have also led to cardiac disease, in addition to possibly leading to cancer diagnoses. But now we're moving some of these into the curative setting. Most recently, evidence is called a Monarch-E trial that was presented 2 weeks ago at our European Society of Medical Oncology. Now we're looking using a year of abemaciclib, showing in high-risk breast cancer patients, showing a survival outcome. And so when you think of a breast cancer patient who's received anthracycline therapy, who has received radiation, and now we're adding another complex drug that can lead to cardiotoxicity. And what about HER2-targeted therapy if we look at the second class? So we certainly know that breast cancer has a 20 to 25% are HER2-positive. GI malignancies, gastric cancers, 13% HER2 positivity, where we use trastuzumab in the metastatic setting. Colorectal cancers and other GI malignancies vary between 3 to 5% HER2 positivity. And non-small cell lung cancer has 3% HER2 positivity. We classically have our monoclonal antibodies, which have really led to, I think, again, the development or reinsurgence of cardio-oncology, because we certainly know that these monoclonal antibodies have led, specifically trastuzumab, to cardiotoxicity with drops in our ejection fraction. But now, as I mentioned, these small molecule tyrosine kinase inhibitors, there's lapatinib, neratinib, dacatinib. Neratinib, I start, and this is the second one here, is because neratinib is now being used in the adjuvant setting for HER2-positive disease, specifically if it's high-risk HER2-positive disease. So after completion of 12 months of trastuzumab, these patients are now receiving 12 months of neratinib therapy. And lastly, these new antibody drug conjugates, which are quite exciting for us. We've had trastuzumab emtansine, so you have your trastuzumab molecule antibody that targets HER2, but also it has a payload of 3 cytotoxins known as emtansine. So it's a direct hit into a HER2-targeted cell. So you can think about whether or not cardiac myocytes are in that hit. The latest one is trastuzumab deruxtecan. So now this is a bigger payload of 8 molecules that are really affect very similar to irinotecan, so SN38. So it's a topo-1 alpha inhibitor in addition to the HER2-targeted therapy. So it's a bigger payload, and in addition, it leads to a a bystander effect, whereby it can actually target other cells around it. So it's actually effective in HER2-low cancers. So when we look at cardiac monitoring, of course, this has been now challenged, I think. In the curative setting, we monitor every 3 months. Well known, if a woman is on HER2-targeted therapy in the curative setting, we're monitoring these patients every 3 months. In the metastatic setting, we are not doing this. And so really the consensus is if a patient develops any signs or symptoms of cardiac dysfunction, then we certainly arrange for cardiac imaging. We'll do a baseline, but certainly when the woman is on treatment for 2 to 3 years of anti-HER2 targeted therapy, we are not monitoring them every 3 months like we do in the curative setting. And they do fine. And as I mentioned, now we're moving these therapies into the curative setting. So if we take a look at breast cancer, in high-risk HER2-positive disease, after neoadjuvant therapy, so this is typically anthracycline, HER2-targeted therapy, if patients have residual disease, now they're getting 14 cycles of this antibody-drug conjugate, TDM1. It is shown that there's a survival benefit. I talked about neratinib, post 12 months of trastuzumab therapy. And now in heavily pretreated patients, so we are looking at heavily pretreated metastatic HER2-positive breast cancer patients, we're now adding tucatinib to trastuzumab, capecitabine, and we're adding TDXD, which is the deruxtecan molecule. Similarly, in gastric cancer, we now have signal that TDXD is very effective in second-line metastatic gastric cancer. And so when we just look at the efficacy of this topo-1 alpha, topo-1 inhibitor, trastuzumab deruxtecan, with those 8 molecules that are attached, 8 cytotoxic molecules that are attached to trastuzumab, this is a waterfall plot. Look at the efficacy here. These are tumors that are responding in breast cancer. When we look at the adverse events of special interest, so we're looking at ejection fraction drops, we're seeing about 1 to 2% in cardiac dysfunction. The published article, the most common here is interstitial lung disease. That's about 10 to 13%. Whether that has an effect on the heart, we don't know, but certainly we look at QT prolongation and changes in ejection fraction, which can vary between, again, 2% to 5% in this population. Similarly, gastric cancer, again, this waterfall plot, significantly efficacious in metastatic gastric cancer with improvements in overall and progression-free survival. Cardiotoxicity, not mentioned in this trial. There was no cardiac toxicity really noted, which was surprising, but lung toxicity, again, is 10%. So we really, as we know from clinical trials, we have these low 1 to 3% cardiotoxicity rates in our eligible, good performance status patients in clinical trials. But when we then move this into the real world setting, we're seeing certainly increases in HER2-positive breast cancer. We're seeing about 15 to 20% changes in ejection fraction, whether symptomatic or asymptomatic. So once again, we're going to have to really follow these patients long term. And lastly, you're going to really hear a lot more about immunotherapy, but certainly immunotherapy and cardiotoxicity, it's there, it's not common. It ranges between 0.6 to 2%. But once again, we are moving these therapies into the curative setting. We are giving in esophageal cancer immunotherapy plus chemo plus radiation within the mediastinum. So we're really going to have to be following these patients long term to see whether or not there are any long-term cardiac changes. But with immunotherapy, certainly we see that it occurs quite early when it does occur. And as Javid mentioned, there is an explosion of positive trials with immunotherapy, typically in lung cancer, melanoma, some GU cancers, but now breast cancer is showing a signal in triple-negative breast cancer with both pembrolizumab and atezolizumab in the first-line metastatic setting, but also in the neoadjuvant setting, where we're giving patients long, about 12 to 16 cycles of immunotherapy in the curative neoadjuvant adjuvant setting. Similarly, as I mentioned, with gastric cancer esophageal, new data that came out just 2 weeks ago with pembrolizumab and nivolumab, with combination of radiation and chemotherapy. And of course, we've known that mismatch repair deficiencies, these tumors are quite sensitive to immunotherapy in the GI space. So combinations with chemotherapy, with radiation and other targeted therapies, HER2-positive gastric cancer, you're looking at chemotherapy with a 5-FU based, you're looking at trastuzumab and pembrolizumab, all being very effective in gastric cancer. And what is your median age? Typically men over the 65 is the median age. So of course, these patients probably have some comorbidities, cardiac comorbidities, and now we're adding other therapies for their cancer. So in summary, as I said, there's many novel therapies in solid tumors. We're becoming more and more selective. I haven't spent any time on oncogenomics and whether or not there are going to be some signals both in leading to cardiotoxicity, but also selected targets in solid tumors. And as I mentioned, these small molecule tyrosine kinases, we're using them in combination. We're using them earlier on in curative disease, and longer term cardiotoxicities need to be followed. Similarly, for these new HER2 targeted therapies, I even talked about the biallelic T cell HER2 targeted therapies that are now currently in clinical trials. Very exciting, very effective therapies. And lastly, immunotherapy. Really, many more tumors are being treated, many drug combinations, and therefore cardiac monitoring certainly needs to be followed. Thank you very much.
Oh, thank you very much, Dr. Brezden. We're going to open things up for questions, and actually, we do have a question for you. So, Dr. Brezden, would you monitor cancer patients in metastatic status like you do with curative patients for LV dysfunction to monitor for subclinical LV dysfunction? We potentially start therapy soon.
Yeah, no, thank you. We actually don't. We put out a position statement now, I think 3 years ago, and we are not monitoring patients in the metastatic setting. And patients actually are doing well. If patients do develop drops in EF, I mean, we have our cardio-oncology clinics that we follow our patients together, but we are not monitoring patients as rigorously as we do in the curative adjuvant setting of every 3 months. And so now that's also some data suggesting, should we be monitoring patients every 3 months in the curative setting? Can we increase that to every 4 months? You know, I think these are studies that are ongoing, and it's a good question that probably needs to be answered.
All right, and then we have another question for I think all of the speakers. What is your personal strategy when it comes to monitoring TKI patients with the current pandemic and requirements for social distancing and less frequent contact with healthcare?
In our hospital, in collaboration with the cardiology department, previously to initiate treatment with BTK inhibitor, our patients are examined by the cardiologist. So because the age of this patient and this disease usually affect older patients. So in most of our patients, previous to initiate treatment with a BTK inhibitor, are seen in by the cardiologist.
Yeah, so what we are doing, so certain drugs, so for example, ribociclib, which needs ECG monitoring at the initiation of therapy, patients are coming in and getting ECG. Now, there are some clinics that are open that patients are getting it at a lab close by to their home with blood work, but they still need to be monitored, and we are monitoring them. We're doing more blood work, not ECG monitoring, but that's more done in outside labs.
So there is one question for Dr. Moslehi about preclinical model of cardiac toxicity induced by anthracyclines. So do you have any model actually working on it or not?
Well, there are a lot of great labs that have produced a lot of nice data modeling anthracycline-induced cardiotoxicity. But my opinion of the data are, it's sort of the blind man in a room with an elephant, where everybody is kind of seeing their own target that they find in their specific model, really just not thinking about all the other models that have been established. And so we have about 10 competing models, not all of them mutually exclusive in terms of what's happening with anthracyclines. So I've made the decision to just stay away from anthracyclines for now. Mostly because I think there's a lot of noise, there's a lot of competing models. All of them could be right in the specific setting. I'm not saying, but I think one of the shortcomings of the field, I think one of the future directions for the field should be that these various models need to be put into perspective in one setting. Like, so your topoisomerase model must fit with the reactive oxygen species model, to the HIF model, to the PI3 kinase model. So there are a lot of competing models, and that's my, at least sitting one step removed from the field, that's my interpretation of the preclinical settings models that we have with anthracyclines.
All right, great. Thank you very much. We have one more question, and then we're going to conclude the session. This is for Dr. Canales. The question: do you have a preferred BTK inhibitor with regard to cardiotoxicity, and what is your real-world experience?
Yeah, in our experience in Spain, now is easy to take the decision because only we have approved ibrutinib in clinical practice. So we have experience with calabrutinib and zanubrutinib in clinical trial. So in the future, probably our election will be a second generation BTK inhibitor because the cardiotoxicity is less compared to ibrutinib.
Okay, excellent. We can conclude this session, I believe. It has been a great session with a lot of insights, and I would like to thank all the speakers and to give the last word to my co-chair.
All right. Well, thank you very much. All of these presentations will be available offline at the end of the session, and I'd like to thank all of the speakers, Dr. Brezden, Dr. Moslehi, Dr. Canales, for your wonderful presentations.
Thank you.
Thank you.
Thank you very much. Enjoy the rest of the meeting.